Caroline, thanks so much for joining me today. Tell me a little bit about the work that you've done and what you're doing now.
Yes, thanks. So I've been a clinician and researcher really in homeless and inclusion health for around the last 15 years. I was a GP for many years in a primary care practice that specialised in people who were experiencing homelessness and asylum seekers and refugees. And I've also worked within a hospital homeless team setting, a multidisciplinary team. But over the last around 7 years, I've also been combining a previous research career with my clinical and looking at addressing some of the really significant gaps that we're finding in people accessing palliative care, who are experiencing homelessness, and the high levels of burden of things such as frailty in this population.
So tell me about what it actually means to be homeless. I think for many of us, homelessness is what we see on the street, but I'm aware that it's more complex than that.
Yes, I suppose I think it's always worth us reflecting on what is a home to us. And a home isn't just a roof over our heads. I think a home is somewhere that we have safety, security, and we have our own space. So homelessness is really, there's a whole range of people experiencing homelessness. It's people who have no place they can actually call a home. So obviously the very harsh, visible and very dangerous edge of homelessness is people that we see on the street, people who are rough sleeping. But there's also many thousands of people who are in insecure, often very poor quality housing, which is temporary. Many people in hostels, which is temporary, but also people who are squatting, who are just invisible. And also people who are increasing numbers of people who are sofa surfing, and what we mean by that is people sleeping on other people's floors or sofas or in corridors.
Can you tell me some of the reasons why people become homeless?
Yeah, sure. So there's obviously many reasons. We know that homelessness is increasing at the moment with increasing poverty and inequality. And there's some real structural causes as well. So things like lack of affordable housing, but also policies around benefits and welfare, housing benefit, those can have major impacts. But another issue that is really important is things like immigration policy as well. So we are seeing increasing numbers of people who are non-UK nationals who have no access, for example, to benefits or public funds, and some are not even allowed to work. And so we're seeing an increase of destitute and homeless people with immigration issues. But in addition, we know there are a number of other drivers of homelessness. So many people experiencing homelessness, for example, have mental health problems, addictions, there have been relationship breakdowns, fleeing domestic violence. And we also know that things such as neurodiversity is associated with homelessness and acquired brain injury. But underpinning often some of these issues we know there's really high rates of trauma and often adverse child experiences, particularly in people who have experienced rough sleeping and end up on the street and with long-term homelessness. So we know that there's a really high proportion, like 85% of people who are homeless and also have an addiction and contact with the criminal justice system have experienced really profound trauma during their lives. So that's, for example, living in a family where there's abuse or neglect, experiencing violence, domestic violence within a family, a parent with addiction, a parent with mental health difficulties, a parental separation. So we know that loss can be a really profound part of homelessness. But also homelessness itself is a risk factor for increasing mental health problems, increasing trauma, increasing risk of acquired brain injury, and an increasing risk of addiction.
That's a huge amount, isn't it? That's a huge amount to be contending with. So what are the health implications for people who are homeless?
Well, obviously people who've experienced trauma are often using substances to self-medicate and often end up with mental health difficulties. Now, not everybody who's homeless obviously has experienced this profound level of trauma, and not everyone who's homeless has a substance use disorder. But for people who have often what we often see and call multiple exclusion homelessness, people have experienced often a lot of profound trauma, have mental health difficulties, and using substances to blank out, self-medicate that trauma. And we also know that people experiencing homelessness are dying phenomenally young. So people with this multiple exclusion homelessness are often dying in their 40s. There's Office of National Statistics have shown that people who are street homeless and emergency shelters, average age of death is in the early 40s. So we know that there's this often trimorbidity of mental health problems, substance use, but also often incredibly profound physical health problems. And what's interesting is those physical health problems are not just related to, for example, TB, which is very high, associated with destitution.
TB being tuberculosis.
Tuberculosis. There's really high rates of tuberculosis, often undiagnosed for many years due to destitution and poverty.
Due to the poor living conditions.
Yeah, absolutely. Yeah. But also hepatitis C, which is obviously associated with intravenous drug using. But in addition to those, we know that long-term conditions such as asthma, COPD, chronic obstructive pulmonary disease, heart disease, strokes are all at a much higher rate in the homeless population, even compared with other deprived populations. And another interesting thing that we found looking with an elderly care lens at a population in a hostel. So we looked at a hostel which was for slightly older people who were homeless. It took people over the age of 30. And they all had a history of rough sleeping. And what we found was, though the average age of people within the hostel was 55, when we looked at their frailty scores, they were equivalent to people in their very late 80s. Gosh. But also really, really shockingly was conditions that you'd normally associated with older people, such as falls and poor mobility and cognitive impairment and even urinary continence, were incredibly prevalent within this population. And staggering still is everybody had multimorbidity, so 2 or more long-term conditions, but the average number of conditions per person was 7. And that is off the scale of any other age group in the population.
So you've talked about long-term conditions, you've talked about frailty. These are the type of conditions that we're seeing a lot of in hospital. Why is it, do you think, that we're not seeing so many homeless people who are end of life?
Well, I think what's happening is that the people experiencing homelessness have so many barriers to accessing healthcare. So often people have other competing priorities or difficulties registering with GPs, even though everyone has a right to primary care. And often people have had really negative experiences. We hear some terrible stories of how people feel very stigmatized when they access health services. And often people's addictions, for example, also are not met. So this together results in people often not accessing healthcare when they really need to, and often only accessing when they have no choice. So often we see in hospital, so working in the hospital team, you see people profoundly unwell coming in straight to intensive care with having collapsed with sepsis. So this means that people are often dying following these emergency admissions and not actually accessing that care and support that we would hope could be preventing and supporting them throughout their journey.
So thinking about when this group of patients might present, and it sounds like people are presenting when they're particularly sick, how can we recognise when these patients might need palliative care?
That's really important. I think a hospital admission can often be a huge opportunity for intervention and for recognition. So, for example, people are often very young, and so it's unpalatable to think that somebody in their 20s or 30s could be in the last year of life. But the reality is, if somebody is having repeat admissions, for example, decompensated liver disease, and those are becoming more frequent, then actually the chances are, unless there's a dramatic shift in how a person is able to cope with, for example, underlying addictions or seeking help, it's highly likely that person is in the last months of life. So I think we need to reframe how we think. So, for example, if we know somebody is experiencing homelessness, potentially has an addiction and long-term conditions, we need to be rethinking, irrespective of age, is this person potentially at risk of dying in the last year? Because what we're finding is that people are dying in really undignified and horrendous ways, with no opportunity for planning or thinking and no multidisciplinary support, which is absolutely vital if we're going to provide some form of compassionate care towards the end of someone's life.
So once we have had a patient flagged to us, how do we best care for them?
Well, I think it's going to be obviously individualised, and everyone's going to have very different needs, but there's a clear need to involve, I think, other disciplines. No one professional group can support this population with this range of complexity alone. So, for example, you might need to be involving addiction teams in the community, frontline hostel or outreach staff, and mental health practitioners or psychologists. These are going to be kind of quite key to providing that support, and obviously GPs as well. And what we often find is that frontline staff, for example, if somebody's in a hostel or street homeless and just attending day centres, frontline staff are often struggling alone to manage people with this degree of complexity, and they really do need support. But in addition, they wouldn't be thinking either in terms of this person's in the last year of life, because that, again, is not only unpalatable, but they're thinking their main remit is to support people out of homelessness in needing into less supported accommodation. But the reality is they're supporting people with increasing complexity, increasing health need, without the support from health and social care. So I think as professionals, as health professionals, we have an absolute duty to try and reach out and support the frontline staff to also support the people that they're working with.
So in palliative care, we like to speak to patients about what their wishes are. And I'm wondering what advanced care planning looks like with this patient group.
I think that's a really important question. I think advanced care planning, we need to be particularly careful with any population that's experienced trauma, particularly where substances are used to blank out and self-medicate. And particularly, we know that people experiencing homelessness have also experienced a lot of loss. So if you're imagining we're dealing with a population who often have not been able to face up to reality before getting a terminal illness, we have to tread very carefully. So the approach that I feel is safest is obviously you need to build a relationship with somebody, to develop trust, which can be a real issue and can take time. But then really to safely explore someone's insights into their illness, where they are now, and explore what's important to them and what living well means to them. And totally be guided by them and their conversation. I wouldn't broach death, dying wishes at all unless it leads there. And conversations can be repeated and over time. I think it's also important that, for example, living well might mean that somebody really has to continue with their addiction. Maybe life trauma has been so deep, so awful, that life can't be contemplated without continuing with alcohol or other substances. So we need to support people to be able to live well for the rest of their lives, and also think about them, what dying well would mean for them.
And in my experience, looking after people who are dying in this population, it can be quite chaotic. And I think it's important to not have the expectations that we might have of people who are in a more stable situation.
Yeah, absolutely. And I think all we can try and do is make sure that people are supported in the way that is comfortable for them. And that might be to stay, for example, within a hostel if they've been in a hostel for a while and that's where they feel connected. But also to take into consideration the support of frontline staff who are also there for them. So I think that's really important. But yes, it can be really messy, it can be really chaotic. But I think we have some great experience of where multidisciplinary support is brought to where people are. And I've seen people with very challenging, complex, difficult behaviours being supported. And as soon as people feel that they're being listened to and truly being heard, that can really be very calming and soothing in itself. So I think it's really thinking about the person, not thinking about what we think is right, not thinking about what we think a good place of care is and what a good death would be, but thinking really in a person-centred way. And concerns are often very different from what we would think concerns are. But one thing I would like to say is that we do know that a lot of people have been estranged from family, and this can be a time where people do want to reconnect. So that is an option that in a way needs to be very safely explored and looked at.
I'd like to talk to you about prescribing for this population. I know that in my experience, when people have addictions to substances, it can be quite tricky knowing how to medicate symptoms and palliate symptoms when people are using other medicines themselves. Is there any advice that you could give around that?
Well, I suppose the only advice is somebody has got an opiate addiction is to bear in mind that often very high doses of analgesia and opiates are needed to tackle pain. And I think it's really important to not consider people are just drug seeking when they are in pain. So there may need to be much higher doses, and that may need a consultant in palliative care or pain specialist to advise, but to not be so fearful about increasing doses to address pain. The other thing that really needs to be considered again is if someone is, for example, on methadone as an opiate substitute therapy, that's usually given orally, it usually entails daily trips to the pharmacist, and obviously there need to be workarounds that. If somebody's getting iller, then they will need somebody to be able to collect their medication, give their medication. These are kind of practical issues that hostel staff are often really up against. So again, that's where the multidisciplinary team working with the addictions team can be really helpful. And also thinking about whether you need to convert from oral medication onto non-oral injectables. So it's really important to think about adequately prescribing for people. Obviously, when we're dealing with a population that have experienced significant trauma, if you underdose, it's not only that you are increasing risk of someone having physical pain, but in addition, traumas that people are using substances to blank out and to numb, they can return. And that's a very harsh, cruel thing to put somebody through when they're dealing with so much else towards the end of their life. Mm-hmm.
So I want to talk to you about how we might creatively prescribe for this population. Can you give me some examples of how we might do that?
Yes, sure. So if we're dealing with a population that may be also living with other people with addictions, for example in a hostel or at risk, then we need to be quite careful about how we prescribe. So things that have worked really well are things like using potentially fentanyl patches, which can be changed every 3 days. Though I will put a word of warning out, the patch does need to be probably supervised, removed before another one is put on, because I have seen people overdose when they've had numerous patches and they seem to have more than 1, 2, 3 on at a time. So fentanyl patches can be really helpful. The other things I've seen certainly in hostel environments is a lockbox in the staff office, because bear in mind, frontline homelessness staff are not health or social care trained and are not allowed or permitted to give anyone any medication. But if there's a lockbox and somebody's on once daily medication, that's somewhere where a district nurse can come and administer medication. The other thing that obviously there can be a real fear if someone might have breakthrough pain, so additional lockbox with maybe 1 dose in somebody's room is another safe way of getting around these issues.
So thinking a little bit about people who might not be in a hostel but might be in temporary accommodation, so they don't have permanent staff, but they might have social care, so they might have a carer coming once, twice, 3 times a day. How could we work with carers in the way that we prescribe?
Well, I think that's really, really important to explore how carers might be able to help somebody in terms of picking up medication, administering or prompting with medication and supporting that. Another issue, I think, actually, which is hostels, temporary accommodation, wherever someone is if someone's alcohol dependent, as they get sicker, they might be unable to buy alcohol themselves. And so obviously stopping alcohol is very dangerous. You can't just stop alcohol abruptly in someone who's alcohol dependent. And that would be a very cruel thing to do as well if somebody is so sick that they can't go out. And so we need to actually also think and maybe work with the addiction teams, but think about how we can actually safely purchase alcohol for somebody so that they can continue with that. And that would be it in temporary accommodation, be it in a hostel, be it in any other environment as well. Obviously, what's different here is we are not going to be in complete control. And I think we need to recognise that that's part of it. What we need to be doing is always thinking we need to be compassionate. We need to be doing what's needed. And that might mean that there are additional risks that we have to take in order to provide that.
Thank you so much. Thanks for joining us today, Carita. I'd like to know a little bit about what your role is.
Okay, so I am the palliative care coordinator with St Mungo's, which is a large homelessness organisation. And I work with any of our clients in the organisation across London And my role involves working with clients face to face to find out what their wishes are, their preferences for treatment, what they want from the future, what their goals are, what their values are, as well as helping to coordinate the care that they receive with St Mungo's staff and NHS staff, social workers, all of those people, helping the individuals themselves to navigate the healthcare system. And also I provide training for St Mungo's staff on homelessness and palliative care. And I work with hostels and other types of service provision. I work with their managers to make sure they are comfortable in allowing people to die in their services, if that is their preference or if that is the reality that they're faced with. So to skill those staff up and to help them with all the practicalities, including things like health and safety.
Right.
And I also work with hospices and palliative care teams, helping them to understand how best to work with people who've experienced homelessness.
So are you able to tell me a little bit about the needs of these patients, of these clients? What are the particular things that, as a healthcare professional, I might need to be thinking about when I'm visiting someone in a hostel or someone in temporary accommodation who would possibly have addiction problems and a slightly chaotic lifestyle?
I would say it's really important for any healthcare professional to try to get to know the person, what their particular struggles are. So you might first find that out from the staff in the hostel or the staff working with them in the outreach teams, to find out what the person is. So they may need you to come earlier in the day if they're a drinker,
right,
so that they're more sober. Or they may need you to come later in the day if they are going to be out in the morning getting alcohol or getting their drugs. So it depends on the individual. Any healthcare professional needs to be able to adapt how they work to meet those people's needs. So that's just when you're first getting to know the person. And I would advise calling ahead before you go, so that you're not potentially disappointed when you turn up and the client has disappeared.
Karita, can you give me an example of where it's worked well working with a palliative care team?
Yes. I worked with a client in a St Mungo's service who had terminal cancer, and as his condition deteriorated, the palliative care team were working with him. And it went very well because the team were very flexible in how they worked with him. And when they needed to get him equipment such as a hospital bed, and he decided that he wasn't going to go anywhere near it, they were able to get him a different type of reclining chair instead that he was more comfortable with. When he didn't want to stay in his bedroom because he was lonely, he was able to be moved into a different room where he was happier. And it was described as his micro environment. A good palliative care team also worked with him we all did advanced planning with him, where he was able to describe what he wanted to happen in the future. But then he did something completely different on a regular basis because he had alcohol-related brain injury and his executive functioning was impaired, so that he would do something completely differently to what he had originally planned for himself. Right. And the palliative care team were great because they accepted this about him. So the goal was for him to be allowed to die at home and to try and avoid hospital admissions. But they acknowledged that he, when distressed, would call an ambulance for himself, go to hospital, and then self-discharge and come back. And it was acknowledging that he had quite a chaotic lifestyle and not trying to force him into a more settled regime that might be more acceptable to us.
Really important. As a healthcare professional looking after this population, I'd really like to know how I can best work with frontline staff like yourself.
I think that it's very important to make sure that we are working in partnership with the frontline staff who are with those individuals on a day-to-day basis, which could be staff in hostels or outreach workers, floating support workers who are going into where the person is living. and to acknowledge that whilst the healthcare professional has more knowledge about palliative care and the health conditions that the person is facing, but the staff who are working with them on a day-to-day basis, they have the understanding of the person and of the wider challenges that they're experiencing, such as substance use or multiple trauma, the fact that they've got care needs younger in life. And also acknowledging that palliative care provides support to family members and to next of kin. That falls part of what palliative care provides. Recognising that in our client group, in the homeless population, they often don't have a next of kin. They don't have their own families. So the hostel staff and the other types of professions involved, they often take the place of family, and they can be quite emotionally involved themselves or need the training to be able to provide the support that they are providing, and they might also need bereavement support after the client has died.
So thinking specifically about people who are homeless, can you tell me about where homeless people are likely to die and what we can provide and how we can support that?
Homeless individuals are often in hostels, temporary accommodations of various types, and that is where they often die. We might want them to be able to go to a care home or a hospice or a different type of environment that might be better suited to providing end-of-life care, but options are limited, and people are often either not accepted to those types of services, or it's just not appropriate, or the routes in are just too limited. So instead they die where they are. When it comes to, for example, hostels, that is not necessarily the type of work that hostel staff realised they were signing up for. It's not what they do on a day-to-day basis, and it's outside of their experience, and it can be seen as a more distressing death, or the sort of death we wouldn't want for ourselves or for our mothers. But it is actually possible to provide good end-of-life care in hostels. So NHS professionals are needed to help those staff understand what a good death can look like and what their part in it can be, and also to support them to do that, so that they can understand that actually this work is really rewarding and can be just as rewarding as the other types of work that they do.
In palliative care, we look after the people around someone who is dying, and that's a large part of our work. Bereavement care after someone's died. I'm thinking about this population. How do we best care for the people around someone who might be homeless?
If we think of hostels as a community of people, that is the staff who are providing the support and the care for the individual, and also the other people who live there as well. Staff can be very affected by the work that they're doing, because they are often in the place of family members and they are with the person day in, day out. So they get very close, and they themselves might need some bereavement support as they process the loss of not only a patient, but also somebody that they've seen every day for quite a long period of time. And the same applies to the other people living there, whether it's in a hostel or temporary accommodation, or all the different varieties of homelessness support accommodations there are. And when it comes to the other people living with them, they themselves have experienced loss upon loss upon loss in their lives, and this is another form of loss. So it's just recognising that in how you provide your bereavement support.
Thank you.
So a trauma-informed way of working is really important when we're working with people experiencing homelessness at the end of life. We know that the average age of death for a person experiencing homelessness is in their mid-40s, which is half the age of the average population. What we also know about people experiencing homeless is that up to 85% have experienced multiple traumatic events in their childhood and throughout their lives. What we also know, what trauma is the lasting effect on that person, on their emotions, their behaviours, and on the way they relate to other people. We also know that for people who have experienced multiple traumas, especially traumatic childhood events, is that it can change the way the brain functions. It'll have a lasting impact on the brain. So we know that those people are going to be really hypervigilant to any threat to themselves, either their emotional or their physical being. And so they're primed to react in that threat response, that fight, flight, avoid, or freeze response. So essentially, trauma can change a person's fundamental beliefs about themselves, their world, and how people around them are going to relate to them. We also know that in palliative care, the diagnosis of a life-threatening illness in itself can be traumatic. Equally, as people become more unwell and they might feel that they're losing control, or they may feel more vulnerable or need help from others, that can mirror the feelings that they had when they experienced past traumatic events. So it can be a really powerful mix. So a trauma-informed approach in many ways is very similar to what we would consider good palliative care. However, the most important thing that we can do is recognise the prevalence of trauma in our population as a whole, but particularly when we're working with the homeless community. We're going to recognise both the prevalence, but also we're going to notice the signs and symptoms through people's behaviour, who might get quite agitated quite quickly, might be very avoidant in their behaviour, and they might be very ambivalent in letting you help them. So when we're working in a trauma-informed way, we really want to try and resist re-traumatising that person through the way we work. People are likely to feel anxious anyway when they're meeting a new person, so take time with your communication to build up a relationship of a trust. Ensure that that person's feeling as safe and calm as possible. Ask questions about themselves and what's most important to them, or what they've been through up till that point, or maybe start asking about their day. The other thing is to be really reliable and flexible as possible in your approach. So ask them where would they like to meet you, what time of day is best for them, and do everything you can to give as much of the control over that appointment as possible to the person you're working with. In many ways, it's very similar to what good palliative care might look like, in that we're building up a relationship of trust, and we're going to give as much power and control as possible to the person, both about the way we're going to work with them, and also over any choices about what they want, where they want to be cared for, what kind of treatment would work for them, and give them as much information as we can, but only if they want it. We recently worked with a young woman called Mai Ling, who had a recent diagnosis of very advanced cancer, and she had been prescribed some palliative chemotherapy and multiple drugs. She'd only had one appointment with the oncology team, but she'd had a recent admission because she hadn't been taking her medications properly, and she'd got such bad constipation that it was life-threatening. We were contacted by the CNS, who was really frustrated that although she'd explained
why she needed to take the drugs, she wasn't taking the medications. The community palliative care team, I went along with the CNS, we went to visit her at home. She was living in a hostel-style accommodation where there were multiple steps. She shared a bathroom with multiple people. And when we got there, she heard I was a social worker and told me she needed better housing. However, when we spoke to her about her experiences, it was clear that all she'd heard from her oncology appointment was that she had advanced cancer and she had 12 months to live. It was really clear that in that appointment, she'd heard that diagnosis and prognosis, and the limbic part of her brain, the back part, had been activated, and she was no longer able to use the frontal processing analytical part of her brain. So she hadn't been able to process any of the further information. They said I'd sent her written information, but because of her traumatic past, she'd not been able to read that information, and her first language wasn't English. We later found out that she'd had a diagnosis of PTSD, she'd suffered severe childhood abuse, and she'd been sex trafficked to the UK. So she'd had multiple traumas. However, over time we were able to build up a relationship of trust. She was taking her medications. She was feeling more positive about her interactions. She did share with us that she was really scared that if she didn't take her medications as prescribed, or she didn't get better, that people would get angry or shout at her, because that had been her past experience of relationships. Myself and the CNS also worked closely with a young man called Glenn who was living in a hostel. He was referred to us by the oncology team because he hadn't been able to attend many of his oncology appointments. He hadn't attended his chemotherapy, and his disease had progressed to a point where it was thought his prognosis could be short. When we first tried to meet with Glenn, he wouldn't turn up to the appointments. We'd come to the hostel at the agreed time. He wasn't there, he'd forgotten, or he'd lost his phone and he hadn't got our texts. But we kept saying that was okay. We kept trying, asking him what would be a good time, we'll come back. And eventually we agreed to meet him in a park where he was more comfortable. He also said he found sitting down quite uncomfortable, so that would be better for him to walk. Over time, we continued going back to meet with him for short visits, and we built up a relationship of trust. To us, he was always very relaxed and very charming, sometimes almost childlike in his approach. And he shared with us over time that not only was he using drugs, but he was also continuing to have sex for money. He also said that he found it difficult, that although it was quite dangerous with his illness, that he didn't want to stop having sex with people, because that had how he'd always had relationships with people, either through having sex or through taking drugs, despite the fact this was putting him at high risk of having a bleed. Over time, we managed to build up a relationship of trust with Glenn. We kept going back, and he shared with us some of his history. He had had a traumatic childhood experience, had been brought up in care for a lot of his life, and had been sexually abused by a religious leader. We might not always know about people's past, they may not want to share, and he didn't talk about it at length, but he wanted us to know about that. What was important to Glenn was he did want to be rehoused, and we supported him with this. It was a long process, and we never got him rehoused. However, by continuing to go back and building that relationship and getting to know him, both us and the dual diagnosis team, we got to know Glenn quite well. He felt that we understood him. However, whenever he went to the hospital, we would report that he became very aggressive quickly. If he was having any treatment at the hospital, he would discharge himself very quickly, and he would tell us that people at the hospital were purposefully humiliating him, laughing at him, and making him feel degraded. We didn't know what the reality of that was, or whether that was the impact of his drug taking, making him very paranoid, but something in the hospital environment was definitely triggering these thoughts. Along with Glenn, we made the decision that he would no longer go back to hospital, and we would care for him at the hostel. We weren't able to reach all of the goals. We did manage to replace some of the drugs he was taking with drugs that were prescribed, but actually it was really powerful for Glenn that he had those relationships with the team around him and was able to laugh and communicate with us, and actually he had quite a good death. When working in a trauma-informed way, we don't need to know about people's trauma, and it's not about getting people to talk about their trauma. We're just recognising that it's most likely there, and to adapt the way that we're working to approach that might be more flexible and more accessible to the people we're working with. So if people don't seem to be engaging, if the treatment's not working, if the medication's not working, we need to adapt our approach. In summary, in trauma-informed working, we don't have to know about a person's trauma. We usually won't know that. But if somebody's reacting in a way that might surprise us or we're not expecting, then there's probably something else going on. In short, it's about building up that relationship of trust. It's about giving people as much control and autonomy as possible. And it's about taking time to find a way through any difficulties.